with the I'm going to talk about the basic physiology about the dengue and how to diagnose, how to manage dengue at the primary care level. I will not be talking about dengue management at ICU level, so please don't get discouraged. And I am Dr. Rajkumar, Associate Professor of Pediatrics at Madurai Medical College. I am also this year EB member from Madurai, and I am also Treasurer of Tamil Nadu ID chapter also. So this will be an informal session where I collected not only myself, we all collected so many questions from practicing pediatricians. We have chosen only 10 for presentation today because of want of time. So the first question, actually, this is in every pediatrician mind: when to suspect dengue fever in the periphery. So some people may say this is not common in our area. Some people will say only you should suspect dengue fever only after monsoon season. Some people will say whenever a child comes with fever for more than a week, then only you suspect dengue fever. But some people say that anytime any child comes with fever, you have to suspect dengue fever. So what's the answer? The answer is D. So no, anytime any child which comes with fever in our setup, nowadays dengue actually is firmly entrenched in our Indian subcontinent, especially in Tamil Nadu. We are seeing dengue cases every month. Even now, so we may get an avalanche of cases after post monsoon, but every month, even during peak winter season, even before rains, and even during peak summer season, we are seeing dengue cases. So we have to suspect dengue fever with any child comes with fever for 1 or 2 days, especially when the fever is very high, 40 degrees centigrade, and is accompanied by at least 2 of the following symptoms. When the child has severe headache or retroorbital pain or muscle and joint pains, nausea and vomiting, and of course with rash, we have to suspect dengue. And one more thing, this is it's a pet idea given by Dr. Professor Thangaveli sir. What he said, sometimes by doing a child comes with fever for 2 days, like fever without focus, you do CBC and CRP. No need to do all costly tests to do diagnose things. CBC and CRP will give a clue. If CBC is showing leukocytosis and CRP is high, we know it is going to be a bacterial infection. And if CBC is showing leukopenia and CRP is high, we have to think that maybe we are dealing with enteric fever. And when CBC is showing leukopenia on day 2 or day 3, and CRP is normal, because dengue, the platelet count may fall by 4th day, so sometimes 3rd day end or 4th day. So CBC shows leukopenia and the CRP is normal, we have to strongly suspect dengue, and we have to do appropriate investigations and appropriate measures. And this has to be, of course, confirmed by NS1 antigen test. So this brings out the second question. This is a common, a burning question asked by practicing pediatrician: how to confirm the dengue fever? Is it clinical diagnosis is enough, or CBC alone is enough? Because this question asked by so many people. Or we have to do NS1 dengue card test or IgM, IgG dengue card test. So how we are going to confirm? None of the above. The answer is because 2015, our Government of India has given guidelines which says that the case of dengue should be diagnosed when the case is compatible with the clinical description of dengue fever with at least one of the following: with either NS1 antigen test by ELISA, or IgM antibody test by ELISA, or IgG seroconversion in paired sera of 4-fold increase, or of course the laboratory methods, the detection of viral nucleic acid by PCR, or culture and isolation. And I beg, practicing pediatrician, please don't order this test, the rapid diagnostic kit for dengue, because the problem is most of these kits, they do not have the expected accuracy. They show a high rate of false positive results. Even the sensitivity and specificity of they vary from lot to lot. So use of this rapid diagnostic test is not at all recommended. So what to do? How to confirm the diagnosis of dengue? The NVBDCP, it recommends only 2 tests for confirmation of dengue in the community level. One is the use of ELISA based NS1 antigen detection test, and this can be possible. This will be positive even from day 1. And doing IgM dengue by capture ELISA, MAC ELISA test after 5th day of onset. Only these 2 tests have to be done. So we're coming on to the third burning problem when we are dealing with that fever case of dengue. That would be the fever management. So what sort of antipyretic measures we have to do to bring down the temperature apart from paracetamol? Because we know that dengue fever has a very high degree of fever in the first few days, and the fever will not respond sometime to paracetamol. So can we use Brufen? Can we use mefenamic acid, aspirin, nimesulide, diclofenac, aceclofenac? The answer is None of the above. No, no, no. These, no. We know that the first 3 days the fever would be very, very high. It will be above 40 degrees centigrade for at least 2 to 3 days. It will not come down even with paracetamol. But for that, if you use these NSAIDs, what happens? They inhibit COX-1 and COX-2, these enzymes. So they reduce the mucosal blood flow. They reduce the first line of defense of our gastric mucosa, the mucus and the bicarbonate layer, and they produce acid back diffusion. They impair the healing. They activate the leukocytes, and even sometimes they produce platelet aggregation problem also. So ultimately, on the 4th day, 5th day, when the child goes into the critical phase with the thrombocytopenia and with the DIVC, when there is a mucosal injury already by this NSAIDs, this is a potent, it's a deadly combination. This results in massive bleeding and child may die because we used unnecessarily these NSAIDs. So what are the measures we have to do to bring down the temperature of dengue fever? We have to use cold depth sponging, of course, and avoid all these NSAIDs, and paracetamol alone at a dose of 10 to 15 milligram per kg body weight per dose, 6th hourly. This is more than enough. And and one more question about paracetamol. Some people asked, when a child has dengue hepatitis, what to do? Can we use paracetamol? We must understand one thing. We always remember that paracetamol causes hepatotoxicity. The problem is in a short period, when a child takes a lot of paracetamol, that is paracetamol poisoning, because of the altered metabolism and glutathione stores are depleted, that results in the accumulation of this hepatotoxic intermediate NAPQ, and that causes destruction of the hepatocytes. What is seen is, even in chronic liver disease patients, those who are having liver problem, and if they are taking normal recommended doses of paracetamol, nothing happens. The cytochrome P450 activity is not at all increased, and glutathione stores are not depleted. So this intermediate doesn't accumulate and doesn't cause any injury. So there is no evidence of increased hepatotoxicity with use of paracetamol in dengue hepatitis, or even a child who is having hepatitis, and we can use paracetamol safely. So this is the 4th burning question asked by practicing pediatricians. If we diagnose a dengue case, we have to immediately refer the child for admission to a tertiary or secondary or tertiary center. So some people may think that, yes, all must be referred immediately on diagnosis. And some people may think, no, I'll refer the case only when it becomes sick after day 5. And this is the answer. The answer would be the C. Very few cases they need referral to a secondary or a tertiary centers, and based on warning signs even before day 5. So what are the risk factors for the development of dengue shock? If these risk factors are there, the primary pediatrician, they should refer the case immediately to a secondary or a tertiary care center for admission, and this child should be managed accordingly. Whenever we see a child we see an infant with dengue, or with comorbidities like diabetes mellitus, asthma, and obesity. Surprisingly, actually, malnutrition, actually, it gives a protection against dengue, it seems. Obesity only results in severe dengue. And female sex, whenever they have comorbidities and female sex, better to refer to earlier, even without development of these warning signs. And in epidemiological profile, if there is a dengue 2 virus infection following dengue 1, actually what they say, the incidence of dengue hemorrhagic fever is very high, almost 3 to 4 times than that of a normal epidemic. So in this period, we have to refer, even if we have doubt, we have to refer the child for admission. So these are the warning signs, the doctors we should look for whenever we observe a child, and we see in OPD basis. Whenever a child develops severe abdominal pain, this should be explained to the parents also. They should immediately bring the child for the doctor's consultation when the child develops all these things. Severe abdominal pain, when there is persistent vomiting, when there is liver enlargement, when the breathing is very rapid, and fatigue, restlessness, and bleeding, diathesis like bleeding gums, nose, blood in vomit, stool, and child develops convulsions and altered sensorium, could be febrile convulsion, or it could be dengue encephalitis. It's a serious condition with a lot of mortality, and jaundice, and of course, laboratory finding showing hematocrit increasing and a decrease in platelet count. Okay, the 5th question, practicing pediatrician, what they want to know is, can a dengue case be followed up in OPD without admission? Some people may be a very cautious approach. No, never. OPD, you cannot follow up the case. And some people may say optimistically, yes, always you can do, no problem. Some people may say sometimes. Some people may say most of the times. The answer is most of the times. almost 70 to 80% of dengue fever cases can be treated on OPD basis, because almost 40 crore dengue infections are happening all over the world every year, and this vast majority of symptomatic infections do not progress to severe disease. The percentage of infections which progress to severe disease is only very less. And there was one beautiful study done in Thailand. Actually, Thailand, being a tropical country, they are also having this dengue problem, and they've done so many studies. If you search in internet, you will be seeing a lot of Thailand's based studies. And one study, they've done a study in children aged 3 to 14 years, and what they found out, the incidence of dengue hemorrhagic fever is only about 11% of confirmed dengue fever cases. Only 1/10 of a child may require referral to a higher center, and dengue shock syndrome occurs in only in 1/3 of these 11%. That is, ultimately only 3% are going to develop this dengue shock syndrome, and 10% may develop dengue hemorrhagic fever. So and we have to give some leeway for another 5 to 10% for, they may be having some comorbidities, they may need admission for observation. So the rest 80% can be treated on OPD basis. This is the message I want to convey to the practicing pediatrician. So how to do this OPD basis, how to manage these people? Actually, there is a pediatric dengue severity scoring system I borrowed from Dr. Tangaveli sir. Actually, this is based on 11 parameters, and all these parameters we already know. We talked about all this, the warning signs and output, bleed, about altered sensorium, the fluid requirement, and about CBC, and warning presence of any comorbidities. So when the score is 7 or more, definitely you have to refer the child for admission, because the child needs observation even when the child doesn't have severe symptoms. But a score of 6 or less, definitely this case can be followed up in OPD. So how to do this OPD follow-up? There are certain prerequisites for doing this OPD follow-up. One is, of course, they should not have any warning signs. Okay. The next one, the child should be able to take oral feeds, at least 3 solid feeds, and child should be able to drink 6 to 8 liquid feeds. And child should void urine at least 5 times per day. And child, even though it lies in bed, but actively moving about in the house and interact with the siblings and parents. And the last but not least, this is the most important, the parents should be cooperative and willing. Why cooperative and willing? Because twice daily they must bring the child to us for for in the OPD follow-up. And in the OPD follow-up, our job is to look for the presence and absence of warning signs, and you have to take a thorough history about hydrogen status, how much fluid the child is taken, how much urine output has taken. There is a chart I borrowed again from Dr. Rangaveli sir. In the next slide, I'll show. And vitals we have to measure. And in the system examination, look for the fluid accumulation signs, pleural effusion, ascites, and CBC. Of course, you look at the hematocrit and the platelet trend. So this is a simple format for OPD follow-up. A simple one page is more than enough.
Sorry for the interruption.
Yes, sir.
Sir, we need 2 more minutes, sir. We have 2 more minutes more, sir.
So this is a simple format where we, for 3 days we have to follow up with the warning signs and with the other lab parameters, as well as the signs, dengue signs and symptoms. So interpreting CBC, this is a most important component. The CBC would be the most important investigation in following up a case of dengue. So which is the most important one? Which one you will see? Because our postgraduates or even primary pediatricians, they are more worried about platelets. Actually, all of the above. You have to look at the WBC count, hematocrit, and platelets. Why? Because the WBC count goes down, hematocrit increases, and platelet comes down. All three they move, and we know that leukopenia and altered NLR ratio, they give a clue about the severity of dengue. And thrombocytopenia and hemoconcentration, we know the child goes for dengue shock syndrome. So a serial value determination showing the drop in platelet and rise in hematocrit is essential. And there is some, looking at the WBC count, we can make some prognostic significance. It takes usually 24 hours before the rise in platelet count. In 82% of individuals, the WBC count increases. And one more thing, the presence of lymphocytes in CBC at the time of admission, it predicts the length of hospital stay. If there is lymphopenia, that shows the child may develop DHF or DSS later. So this will be particularly useful in remote areas with limited laboratory facilities. The one more, latest CBC, if you order for CBC, order for 5-part CBC, because there is some prognostic significance of immature platelet count. This gives a clue indicative of platelet recovery within 24 to 48 hours. This is nothing but like our reticulocyte count for doing for anemia. And these normal values are 1.1 to 6. Whenever you have IPF, the immature platelet fraction is more than 10%, you know that platelet is going to recover within 24 to 48 hours. This will be useful in periphery setup. When you have a platelet count of 20 to 30,000, you are worried platelet count may fall down further. When you look at the IPF, if it is more than 10, don't worry, the platelet is going to rise from now onwards. So I put one example for that. Within 6 hours, the immature platelet fraction showing 31%, the platelet count is started increasing. This is the another dilemma. A child admitted for just melena and child is everything is fine, but parents want platelet or blood transfusion. Will you agree? No. Refuse. And why? Because the child can be managed conservatively with the simple measures and the watchful waiting. You know, in olden times, we used to tend to chase platelets. We were given multiple transfusions at various platelet threshold. It was reinforced by patients and family members, and this resulted in exorbitant cost to the admission and danger to the child's life. Why it is danger to the child's life? Because we know dengue causes damage to the endothelium that results in release of ultra large von Willebrand factor, and ADAM TS3. This is an enzyme which actually, this disposes of this large von Willebrand factor, and in dengue, which results in deficiency of ADAM TS13 and the release of large von Willebrand factor. So if you give platelets, you are going to further worsen the injury by producing more for platelet plug and microangiopathy. So this will cause more harm than good. There are only few indications for platelet or blood transfusion when the platelet count is less than 10,000 or there is external or hidden hemorrhage.
Sir, sorry for the interruption, sir. We are exceeding our time limit, sir. So
only
we'll
one
be
more
taking up the, please, sir, please, sir, please, sir.
Okay.
Yeah.
Okay. The fever returning after day 7 of illness. Sometimes, when the child of dengue, everything is fine. The child was improving on day 8. If the child developed a fever on day 8, what could be the possibility? Is it sepsis or co-infection or hemophagocytic lymphohistiocytosis? The answer is all. Look for sepsis. Sepsis commonly sometimes accompanies dengue infection, and co-infection with the enteric fever and malaria also, they are nowadays common. So look for those infections. And HLH, please don't forget, secondary HLH can occur after day 7, day 8 when there is persistent fever with the cytopenias. And the last one is the prophylactic use of colloids. Will it prevent the occurrence of DSS? This is a question asked. Preemptive use of colloids have no role. This didn't provide any benefit over crystalloids, has no prophylactic role. The colloids use are only during the critical phase in the management of shock after 2 crystalloid boluses, or when the management of shock is and child is having leaking fluid, and a crystalloid is just leaking out of the vascular space whenever it is being given. And please remember that these colloids can cause a lot of problem, especially with coagulation problem and allergic reactions. So these are the take-home points. You suspect D fever in any child with high fever in the peripheral setup and confirm it by doing NS1 antigen by ELISA and use paracetamol as the sole antipyretic. Almost 78% of D fever can be treated on OPD basis. What we have to do is identify the warning signs early and refer them as soon as possible. And CBC gives a lot more information than looking at the platelet count. And don't go for prophylactic fluids or blood and platelet transfusion. Thank you. Thank you for the opportunity given for me. Thank you, sir.
Thank you very much, sir. I have not introduced you at the first slide because it was I just missed the slide. The sir is from Madurai Medical College. He's an associate professor and he is very much interested in teaching. He has got a very good presentation for which is fit to be for the PGs, and usually it is going to be taken probably in some other session on dengue. So
thank you, sir. Thank
one point which we are trying to make is we need to do the test only after 3 days.